Everybody's doing a brand new dance.
All right, whenever you are ready, just state your name, and then a couple seconds later, then go on. That was the chair, I promise.
Hello, I'm Dr. Robert Brown from Weill Cornell Medical College. And on behalf of the Chronic Liver Disease Foundation, I'm pleased to present this presentation on primary biliary cholangitis, or PBC, diagnosis and treatment options. Primary biliary cholangitis, which previously was called primary biliary cirrhosis, or PBC, is a chronic cholestatic liver disease which is autoimmune in nature. The autoimmune target of destruction are the small interlobular bile duct cells. It affects predominantly middle-aged females and is having a rising incidence and prevalence, perhaps due to increased screening and detection. The diagnosis of PBC is based on the following three criteria: an unexplained elevation of the alkaline phosphatase, or ALP, greater than 1.5 times the upper limit of normal, a positive antimitochondrial antibody, and a biopsy showing non-suppurative destruction of the bile duct cells, or cholangitis, on histology. 2 out of the 3 criteria are required for the diagnosis of PBC. Thus, in patients with a positive AMA and elevated alkaline phosphatase without any other explanation, do not need a biopsy for diagnosis. There are some important variant syndromes that we need to address. The first is AMA negative PBC. 50% of these will have an anti-nuclear antibody that's positive. One can send the PBC-specific ANA, called anti-GP210 and anti-SP100. These have the same clinical presentation with elevated alkaline phosphatase and may have a reduced survival compared to the AMA positive variant. However, with a positive ANA, one has to concern themselves with the possibility of an overlap syndrome with autoimmune hepatitis. A key clinical pearl is to consider overlap syndrome when the ALK-phos to transaminase ratio is less than 1.5, when there is an elevation in IgG rather than an elevation in IgM, which we tend to see with PBC, and if the smooth muscle antibody is positive at an elevated titer. When there is a concern for AMA negative PBC or overlap syndrome, frequently a biopsy is required to make the diagnosis, certainly prior to initiating immunosuppressant therapy. And finally, there is a premature ductopenia variant, which occurs in about 5 to 10%, with very rapid onset of ductopenia, very severe cholestasis and jaundice, and rapid progression towards cirrhosis. For the majority of patients, the clinical presentation is asymptomatic. They will simply have abnormal liver function tests, and then hopefully during workup be noted to have a positive AMA. When symptoms are present, they will often be rather vague: pruritus, fatigue, dry eyes, or Sicca syndrome. Cirrhosis is present in only 5 to 10% at the time of diagnosis, and this is why we've changed the name to primary biliary cholangitis. However, portal hypertension can occur even in the pre-cirrhotic patients with PBC. The management strategy as recommended by our professional societies is shown here, and involves both a baseline evaluation, the initiation of PBC-specific therapy, and then follow-on monitoring. At the time of evaluation, we certainly want to do our labs, assess symptoms, but staging needs to be done. For unclear cases, this will be with biopsy, which will both provide diagnosis as well as staging. However, in patients in whom diagnosis is clear, non-invasive measures of liver fibrosis or staging, like FibroScan or transient elastography, or serum markers can be used. Because of the high frequency of vitamin D deficiency and osteopenia/osteoporosis, it is important to get a baseline bone density and vitamin D level. DEXAs should be repeated every other year. PBC-specific therapy should be initiated. The initial treatment is ursodeoxycholic acid, or UDCA, at a dose of 13 to 15 milligrams per kilogram per day, divided twice or 3 times a day. Over time, the patients need to be followed for whether they have cirrhosis, either based on non-invasive markers or the presence of thrombocytopenia. Any patient with cirrhosis needs our normal cirrhotic healthcare maintenance. This would include screening endoscopy for varices and hepatocellular carcinoma screening with twice annual imaging. And we need to follow the patient's liver biochemistries with risk stratification, either nowadays closer to 3 to 6 months, initially at 1 year. And that will lead to the evaluation for adjuvant therapy. And then patients who are non-cirrhotic will need some ongoing assessment of progression. Increasingly, we are using elastography for that purpose. UDCA, or ursodeoxycholic acid, or URSO, is still our first-line treatment. It is an orally administered, naturally occurring hydrophilic bile acid. It replaces your bile acid pool with a more hydrophilic, less toxic variant. It's dosed, as I said, at 13 to 15 milligrams per kilogram per day. And we generally see improvements in liver biochemistries within a few weeks. 90% of the improvement that we will see overall will occur within the first 6 to 9 months. Thus, at 1 year, the number of patients who achieve biochemical remission, according to either the Paris criteria, is 66%, or the Barcelona criteria, a little lower. So up to 40% of patients have a suboptimal response. Now, the therapeutic effects of UDCA, in addition to improving liver biochemistries, are improvement of survival, transplant. I'm going to redo this one. The therapeutic effects of UDCA, in addition to improving liver biochemistries, is that it has been shown to improve transplant-free survival. And that improvement in transplant-free survival correlates with improvement in liver biochemistry. This is related to delay in histologic progression, complications of portal hypertension, and additionally, improvements in cholesterol and lowering of the IgM level, which allows you to have another biochemical marker for response. Thus, it's important to risk stratify patients with PBC, either according to one of these criteria, Barcelona, Paris, Rotterdam, Toronto, or Mayo. Simpler is to use the APRI, which is quite specific for the presence of cirrhosis, or using one of the mathematical models, many of which are available on smartphone apps or on the web. The GLOBE score, for example, is an online calculation which takes the age of initiation of URSO, bilirubin, alk phos, albumin, and platelets after 1 year of therapy and predicts 3, 5, and 10-year survival. Now, for the 40% of patients who fail ursodiol, meaning they do not achieve an adequate biochemical response, or those patients who are intolerant to ursodiol, there was a need for a second-line agent, which has been recently approved, obeticholic acid, or OCA. Though it is a bile acid, it works through a completely different and novel mechanism as an FXR, or farnesenoid X receptor agonist, which affects bile acid homeostasis, and through these four mechanisms increases choleresis, or excretion of bile acid, as well as acting on the inflammatory pathways to decrease inflammation and thus resultant fibrosis. Because it works through a different mechanism than UDCA, it can be used as an adjunct to URSO as well as an alternative in intolerant patients. The approval of OCA was based largely on the POISE study. This was a 3-armed, randomized, placebo-controlled trial comparing placebo to OCA at 10 milligrams and a dose titration in which patients were started on 5 milligrams of OCA and either stayed on 5 milligrams of OCA or went up to 10 milligrams of OCA at 6 months if they had an inadequate biochemical response. All patients at year 1 were then rolled over into a 5 milligram arm, or if they were already on 10 milligrams, a 10 milligram arm. Patients on placebo who got 5 milligrams and had an inadequate response in the open label could be titrated upward at 3 months. The criteria for titration was failure to meet the primary endpoint of an alkaline phosphatase less than 1 2/3 or 1.67 times the upper limit of normal, or a bilirubin that was abnormal. So when we look at the primary endpoint of achieving an alk phos less than 1.67 times the upper limit of normal with a reduction of at least 15% from baseline and a normal bilirubin, you can see that both OCA arms achieved a statistically significant benefit compared to placebo. Though initially the 10 milligram arm achieved faster reductions in OCA, I'm going to have to redo that one.
No problem.
When we look at the results of the POISE trial in terms of reaching the primary endpoint of an alkaline phosphatase less than 1.67 times the upper limit of normal, with a reduction of at least 15% from baseline and a normal bilirubin, we can see that both OCA dosing regimens, 10 milligrams and 5 milligrams with dose titration, achieved a statistically significant improvement in normalization or reaching that primary endpoint compared to the placebo arm. Though that 10 milligram dose achieved it a little more rapidly, by 12 months, both the dose titration and the 10 milligrams dose achieved similar rates of meeting the primary endpoint at about 45%. One can see in the open label arm that the placebo patients rapidly caught up to the patients who were on obeticholic acid in the first year, though the patients who received OCA throughout remained numerically higher throughout. Now let's look in a little more detail. We can see here that during the double-blind phase, alkaline phosphatase, which was started at a mean over 300, remained stable in placebo and were reduced significantly in both OCA arms. Once the placebo patients were switched over, they all converged at the end of 2 years. Similar results were seen for bilirubin, though bilirubin started out relatively normal, where you see modest reductions in the OCA arm, modest increases in the placebo arm that reversed once they were switched over to open label OCA. And we see similar results for GGT, AST, and ALT as shown on these 4 graphs. If we look at markers of immunity and inflammation, we see reduction in IgM levels in the OCA-treated patients compared to placebo, but no changes in IgA or IgM. CRP, TNF-alpha, and IL-12 were not as consistently effective. However, IL-12 and TNF-alpha did, I'm sorry.
No problem.
Looks like they were all statistically significant. I'm sorry. Gotta redo that one.
Go right ahead.
Right. When we look at markers of immunity and inflammation in the double-blind phase, we see reductions in IgM levels. We see smaller but still significant reduction in IgA and IgG. We also see reduction in CRP, TNF-alpha, and IL-12 in the OCA-treated patients compared to placebo. When we look at the impact on lipids, we do see a small decrease, but it is statistically significant in the HDL levels in OCA patients during the double-blind phase, though one can see here that HDL levels remain high throughout that period of time, and these converge once patients are on open-label therapy. No statistically significant difference over time is seen in LDL levels or, I'm sorry, that's statistically significant for the, so hard for me to read that slide there. I think, well, I know what I'll say. All right.
All right, hold on.
We're going to redo that one.
Okay. Whenever you're ready.
When we look at the impact of OCA on lipid levels, we do see a statistically significant reduction in HDL cholesterol during the double-blind phase, though it is important to note that HDL levels remain high on OCA therapy. Smaller changes are seen in LDL, total cholesterol, and triglycerides with OCA therapy, but monitoring of lipid levels is recommended during obeticholic acid therapy. When we look at the adverse events in both the double-blind POI trial and the open-label extension, you can see that pruritus does occur at a higher frequency in the OCA arms than in the placebo arms, at somewhere between 56 and 68% compared to 38%. Other side effects did not occur at a significant difference other than the possibility of fatigue in the high-dose arm. One can see that all of the other effects were relatively similar. When we look at the pruritus scores numerically, if we look using the pruritus VAS scores, you can see that all 3 arms had an increase on initiation, but that the high-dose arm had a statistically significant increase early on, and that the dose titration mitigated the increase in pruritus seen compared with placebo. So the overall findings were the effect of OCA was consistent and independent of age at diagnosis, duration of disease, and the height of baseline alkaline phosphatase. Titration from 5 to 10 milligrams based on the clinical response improved the tolerance, reduced dropouts due to pruritus, and showed comparable efficacy to 10 milligrams at the 1-year endpoint. Thus, starting at 5 milligrams with titration to 10 milligrams appears to be an appropriate dosing strategy and is what is recommended by the FDA. When it was given to patients with PBC who had an inadequate response, or those that were unable to tolerate UDCA, we produced a significant, clinically meaningful improvement in liver biochemistries, which has been shown in prior studies to correlate with clinical benefit, i.e. transplant-free survival. Thus, this is the approved indication for OCA, treatment of PBC in combination with UDCA in patients who have an inadequate response, or as a monotherapy in patients unable to tolerate UDCA. When we look at the long-term management of PBC, these are the AASLD guidance documents. Liver function tests every 3 to 6 months. Checking of the thyroid function test annually due to the high frequency of hypothyroidism. Bone density every 2 to 4 years. I personally do every 2 years. Monitor for fat-soluble vitamin deficiencies in the setting of advanced cholestasis. I monitor 25 vitamin D regularly and vitamin A less regularly. If both are deficient, I replace with A, D, E, and K. If only vitamin D is deficient, vitamin D supplementation will be sufficient. If the patients are cirrhotic or have a Mayo risk score over 4.1 or a platelet count under 140,000, endoscopic surveillance per our standard every 1 to 3 years, and additionally HCC screening with ultrasound, with or without alpha-fetoprotein, every 6 months in patients with known or suspected cirrhosis. Thank you for your attention.
Okay.
I didn't know, maybe I should say something else.
Yeah, dude, it sounded like you wanted to continue that
Yeah,
sentence.
I know,
Just go ahead and...
Usually I say good evening, but these are time independent, so all right, I'll redo the thank you for your attention.